ongoing review by REBs of who's been accessing them, what's been happening, and so on. So there's oversight governance, heightened security, and a biomedical range of, that is consented to. So this is a systemic model. So P3G, and this just came out 2 weeks ago, how do I put it, qualified its no return results, just like I think the UK Biobank will probably be doing, saying that there may be cases, even in longitudinal studies, where you do want to change your mind because the researchers using your resource are doing next generation sequencing, and they're going to have interesting things. And you're doing a longitudinal, you can recontact. Longitudinal means you have an automatic recontact mechanism, and there you may want to change your policy. So my last model is one that's been severely neglected, except in Europe and a little bit in Canada, and that is what happens for pediatrics. And this is what I call the dynamic model, and it's my conclusion. The pediatric community, as you know, is a highly, I must say, relationships in pediatric research or pediatric clinics are usually very close. However, in this study that I did of 65 consent forms in Canada, pediatric consent forms, we found there was a whole range of promises, what to return, not to return, and so on. All of these clauses came before the 2010 muddled statement that you saw earlier. So in a consent that I did for a pediatric project on rare diseases, we said, obviously, there has to be a plan. That's like Canadians now have to have a plan for communication. But we made a specific exception for pediatrics. Contrary to literature emerging from here, parents are not allowed to choose not to receive incidental findings of clinical significance if they are actionable, i.e. preventable or treatable, during childhood. Okay, so we're not talking late onset. In other words, the normal choices that parents have for their children cannot be exercised in the pediatric context when it comes to those kinds of findings. It would be considered neglect. And this has just been taken up by the European Society of Human Genetics. They took the same position that parents have a limited right not to receive this kind of information. So in conclusion, as a law professor and a practicing lawyer, I argue for guidance, not regulation, except I would agree with the earlier speaker for mandatory data security. Generally, however, in these fast-moving fields of genomics and emerging technologies, NGS today and something else tomorrow, guidance that can be updated and scientifically immediately valid and useful is the best way to frame a genomic research. For return of results, those same criteria remain: validity, utility, and actionability. Keep it simple. Distinguish context. Distinguish population from patients, from pediatrics, from incompetent adults, and so on, who are more vulnerable. And you don't need elaborate. The principled level is the way to keep it so that responsible researchers and their IRBs and their institutions can actually exercise their professionalism. And any narrow interpretation will do more harm to science than you can possibly imagine, particularly international collaboration and data sharing, which is extremely important considering the public investment in genomic research, that you be able to gain statistical significance by not putting barriers around the international sharing of data. And sorry about the PS, I can say it because I'm a lawyer.
No apologies necessary. We're going to catch up and get back on schedule, so we're going to have a hard stop at 11:30, and I see Anita Allen's hand up, so we'll begin with Anita.
Okay, thank you. And I want to start sort of toward the end of your presentation. It's interesting what you said about the approach you took toward children, where the parents don't have a right not to receive the results of research where it could help the child during childhood. And I'm just sort of wondering about that line, because I'm thinking about families that have children with disabilities, where the children's relationship with the parents it goes on far beyond childhood. And even just thinking about the fact that there's just so much family interdependency, that if you have a health issue in a family, just because you may be 27 when it first arises doesn't mean that mom and dad aren't going to be there for you and be involved in your care. So I'm just wondering, why would you draw that line at, conditions that would develop during childhood, knowing the reality of interfamily dynamics and connections, and again, especially in the context of disability, or even just simply in the context of ordinary family life.
I think there's no doubt where there's other, and I put quid at the bottom of one of my slides, when you're dealing with, I put quid incompetent adults, shouldn't the same hold true? I could have put quid dependent disabled person, shouldn't the same hold true? So when we're dealing with vulnerable, I could probably say yes to what you're saying. However, for children, and then I'm only limited myself to that category, as legally defined, parents have authority till legal majority, which they are bound to exercise. And for that reason, when you create a professional norm, which then becomes a standard of care, you have to be very careful that if you're going to create other norms, and I agree with the areas that you would like to extend this particular norm to, that you don't create